Welcome back to Crush Medical. We've got another high yield board examination question here. Make sure to like and subscribe, help this channel grow so we can continue putting out more free content that will help you guys. Check us out at crushmedical.com where we've got free resources, we've got premium mentorship, coaching, interview prep, as well as a flagship bundle that we've just launched, and a lot of interest is garnering from there. So check that out as well, okay? Let's jump right into this question. 45-year-old woman who has chronic schizophrenia has been maintained on risperidone for 2 years. Over the past few weeks, she reports the return of auditory hallucinations, though less intense than her previous episodes. She has no suicidal or homicidal ideation, is sleeping and eating normally, and continues to work part time. A pill count and pharmacy records confirm good adherence, and she is currently on a low to moderate dose. Which of the following is the best next step? So, quickly, let's just unpack this question. We have a patient, 45-year-old woman, who has chronic schizophrenia, meaning she's been on this medication for a long time, right? She's on risperidone. That being said, she reports the return of her auditory hallucinations, right? Um, so we can't call this stable anymore, right? It was stable, and now she has a return of some of her symptoms. So that is one concern there. But outside of that, she has no suicidal ideation, homicidal ideation, and more importantly, she's sleeping, eating well, and continues to work. So she's still a very functional person outside of her auditory hallucinations. Um, and of course, the pharmacy, the pill count, those records confirm that she is actually in fact adherent. She's not skipping doses, and she's on a low to moderate dose. So now that we've built that framework, now we can kind of go through the options and see what is gonna be the most beneficial for this patient. Let's start with option E, okay? So arrange an urgent psychiatric hospitalization. This would be incorrect here, right? So again, any of her symptoms do not warrant immediate hospitalization or psych admit for that reason. Again, so admission, this is for safety concerns. Does she have suicidal or homicide ideation? Is she a threat to anyone? Is she completely withdrawn to the point that she just stopped eating, stopped, caring for herself? Now that would be some grounds for admission for a psych admit as well as hospitalization, right? In this case, that doesn't seem to be the solution for her, so we can say that is incorrect, okay? Option D, switch directly to clozapine, okay? That's interesting. So this patient, she's a chronic schizophrenia, and she's been on risperidone for 2 years, so she's been taking it for quite a while, relatively stable, however, recent auditory hallucinations. Does that warrant switching this medication to clozapine, which is its own medication as well as has its own side effects? So that would probably be incorrect here, right? So clozapine is for treatment resistance schizophrenia. So essentially, they will say a patient who has chronic treatment resistant schizophrenia for 10, 15 years, has tried numerous medications, nothing seems to be working. That is the ideal candidate, and that is how the board will describe the treatment for someone who should be switched to clozapine, right? In this case, this is just not the correct answer here, right? And considering she's on a low to moderate doses, I think there are some other things we can look into before we even talk about switching drugs, okay? So option C, starting a mood stabilizer along with the antipsychotic. So this is interesting because she's not complaining of any mood concerns, right? She mentions that her auditory hallucinations dealing from the schizophrenia has returned, but she's not talking about any instability. She's not talking about depression. She's not talking about irritability. She's not talking about sleepless nights, spending all of her time staying up and doing interesting things. So for that, the mood stabilizer, which in fact does play a role in helping some schizophrenic patients who deal with depression and anxiety, but that is not what is going on here, right? So this would be incorrect here. Her breakthrough symptoms are psychotic, not mood. A mood stabilizer doesn't target the active problem, right? So interesting, but let's keep moving forward. Option B, adding a second antipsychotic to the current regimen. So now we're kind of getting closer as to how we can actually optimize her current medication regimen. In this case, option B is suggesting keeping that low to moderate dose risperidone and adding a second agent. And therefore she would be on two antipsychotic drugs. That's just not ideal for this patient, right? This is called polypharmacy, a high yield term to be aware of when a patient essentially takes multiple medications that have different interactions as well as side effects, and ultimately can harm the patient instead of providing them any benefit, right? So that's polypharmacy, and that's not something we would want for this patient, right? So in this case, it has side effects with little added benefit. Don't add a second agent until the first reaches an adequate dose, right? So that is essentially where we're going with this, and that is option A, which is increasing the risperidone towards its maximally effective dose, which is the correct answer here, right? So now we're maxing out her risperidone to ultimately control those auditory hallucinations, and I think that is not only what's ideal for this patient, that is what would be best, right? Like, why we can't really, she's on a low dose, so we can definitely step her up. We don't need to add any second medications, and outside of that, she's very much a functional adult, right? So that is extremely important. And let's just kind of go over these bullets really quickly. She's adherent. She's not on a high dose, so we can escalate this and maximize that. No safety risk, so she's not at risk for suicidal ideation or homicide. She's functional, sleeping, eating well. And again, big bullet is avoid premature polypharmacy. We don't need to start her on multiple medications. And again, the high yield bullet, just be aware of, is to ultimately, we want to optimize the current drug's dose first, right? Low dose, moderate, let's bump it up. Medium to high, and see if those symptoms completely resolve. And if that's the case, we did great, right? So again, this is another high yield examination question. Psych, they love their psych drugs, so be aware of that as well as side effects. And ultimately, polypharmacy is another very important diagnosis as well as concept to be aware of, okay? So if you enjoyed this question, make sure to like and subscribe, and we'll see you in the next question.